Well, thanks, Ahmad and Joe. That was a great presentation you did for our team on partial dentures, kind of partial dentures 101. So much has changed in partials in the last 5 or 10 years, but a lot of the things remain the same. What's the same about partials and what's different?
Partials, I don't think will ever change philosophically and design-wise, those sort of things. And the reason being is that we do a lot of this. Most of our partials are done digitally now. They're designed on a computer. They are then, cast, not even cast anymore. These are printed chrome cobalt partials that we get. But the design, everything about partials is the same as far as design, execution of the case itself.
Instead of a surveyor, you're using a computer.
Your computer. The computer becomes the surveyor.
Just like an architect not using a drafting board, they're using a computer.
So finish lines, internal finish lines, external finish lines, rests, everything about components of a partial are put into the computer, programmed in the computer from information that was taught years ago.
So Ahmad, he mentioned at ROE Dental Laboratory, we're doing our partials with laser sintering now with SLM technology. What are the advantages of that over casting?
The advantage is that the casting is the room of error is almost slim to none. With the manual casting, there is more room for errors. It's like when you cast, the expansion in the oven for the rings. When you cast, you have miscasts, you have porosities, you have pits. With the new technology, it's very much all laser sintering. So there is no room for error, no porosities, no warping. We know it's got to fit.
So we talked about, back to the fundamentals, the Kennedy classes of partials. Which of those are the biggest challenge for the clinician to restore?
The Kennedy Class 1, which is a free end distal extension partial, it's not a challenge to restore, but it's probably the most difficult one to design for longevity. If the correct clasp isn't designed on there to reduce that, and minor connectors aren't placed in the correct position, they can cause tooth loss. Any partial with a free end distal extension on it, the abutment tooth, is always at peril.
So a badly designed partial is really a tooth extraction device.
Tooth extraction.
Okay.
Yeah.
So Ahmad, regarding major connectors, often we have requests for or we design cases with anterior posterior straps on a maxillary case. Why would we do that? What are the advantages for the doctor to do that? The
advantage for the doctor to do that, two things. First, sometimes the patient has tori, growing bone in the middle of the palate. So it allows us to go around it, open it so the patient doesn't press on it by the metal. The second advantage is if we have missing posterior teeth on both sides of the upper, we do anterior posterior. It's the strongest design. So it will support it anteriorly and posteriorly so it doesn't bend. And sometimes we use it also when the patient is Braxtor because he bites very hard, it tends to warp the framework. So the anterior posterior is the strongest design.
Sometimes doctors give very elaborate instructions on how to design their partials, and sometimes we just say, upper partial, lower partial. What are the advantages and disadvantages of doctors being, very specific in what they want with their designs?
The advantage for us as a technicians give us the freedom, the choice to examine the case and design it the way we think it's gonna work. And the disadvantage about us designing it, we don't know what the patient wants. Sometimes we have to communicate with the patient to see what they like. Some of them we recommend lingual plate, the patient don't like the metal to feel it with the tongues. And sometimes we use AP bar, as I mentioned before. The AP bar is very strong design, but sometimes it's uncomfortable because you gotta feel the back strap on the upper
dialogue with the patient to know, hey, what to get the doctor to get a feel for what they'd accept.
It helps us a lot because so many times we do design them, they work fine, they function fine. Remake it, the patient didn't like it, didn't like the feeling of lingual plate, or didn't like the feeling of the lingual bar. He wants a lingual plate. So this kind of info, it helps us a lot.
Any more thoughts on that, Joe?
Yeah, we get prescription, again, a spectrum of results. We'll get a prescription that says make upper partial denture, which gives us poetic license to do whatever we want.
Right.
Okay? Then we get instructions from doctors that fill the entire prescription. So somewhere in between is, what is easiest for us in the lab. In other words, try to be concise, try to be succinct, organized as far as how you put your steps that you want us to do, and try to eliminate things that we don't need to know.
And certainly, mobile teeth
Mobile
teeth that are very strong and very good bone. We don't have the X-rays when we're looking at most
We
of those.
don't.
That's probably significant as well.
Well,
right?
I mean, if we know that, we won't put a clasp on it.
Right.
Yeah. So mobile teeth are a big thing that we would never know. We could tell by looking at the model maybe that there's a lot of recession or the teeth are splayed out all over the place. That gives us some sort of an indication, but it'd be nice to know that.
Great. Well, thanks again for
Thank
the
you.
presentation for everyone today. That presentation is available to watch for anyone that's interested. And thank you both for your time putting that together.
Okay, thank you.
To receive a copy of this lecture, visit www.rodentallab.com/ROE Reviews.